and then two big things that they have to have either been intubated in the past or that they have had to have epinephrine for an asthma attack. That's a big like red alarm should be going off somewhere for you. That's bad asthma. So anytime you've got somebody in that situation, you want to try and maximize their position before you take them back to the operating room. So, and I don't mean a physical position, I'm talking about their physiologic position. So, a lot of times, what I'll do with those patients is start off with a combination of a duo-neb treatment, or if you don't have that available, just albuterol. In pre-op, you may even consider a second treatment. You may try and get some long-term steroids into them ahead of time. So, like solumedrol, 125 milligrams, that may be helpful for them. You may also try and avoid triggering things for them. If it's exercise induced asthma, or maybe, it's allergy season or something like that, you may try and schedule the operative intervention around those sorts of things. Sometimes those people get short of breath just walking up the stairs, so you can't do much about that. But, if you can get it in this season where they're if you can get it in a season where they're not having issues, it's a little bit easier for you. So, from a preoperative standpoint, things I would think about getting him an albuterol treatment or a duodenum treatment ahead of time, some steroids, and then you start thinking about things you're going to have to do for his airway. So he's morbidly obese. He's 150 kilos at 5 feet tall. He's tachycardic at baseline. He's got a short, fat neck with very poor mouth opening. Incidentally, yesterday I had a patient whose mouth opening was so poor I couldn't even get my pinky finger in there. We wound up doing an awake nasal intubation on them. MPO status is good. Labs weren't real exciting. His hematocrit's 40. He may be a little hemoconcentrated. You're going to need general anesthesia for this procedure. So regional is not an option. So with that in mind, what are you guys thinking about other things you may need as far as positioning, devices? What might be helpful for you? Yeah, so things I would think about, and if you've done the case study, you kind of already have the answers. But good positionings to start. So getting him a ramp, either like an intubating pillow or blankets. I would make sure I had the glide scope in there. I probably would not start off with a fiber optic intubation on this patient, but that was what the case study wanted you to do. So I'd probably start off just yelling and have the glide scope available. Um, a lot of times you'll see with these patients that an awake fiber optic can be really difficult, but that's okay. So those are the two big things you really have to keep in mind for this patient: his asthma and the potential for a difficult intubation. So things I would consider for this patient: make sure he's well pre-oxygenated. Um, like I told you guys in SimLab, that pre-oxygenation period is really kind of your cushion as the resident, because when patients start to desaturate, people start to get a little bit antsy. Another thing for you to think about with this patient is getting a baseline O2 set. So if he's starting off at 90%, he's probably not going to be 100% by the time he's done. So when you get to recovery, you need to have realistic goals for this patient. Getting him to 90% and keeping him there before discharge is probably appropriate. He's probably not going to be miraculously better and get to 100% to go home. Other things to think about: you can go back and forth on a couple different theories. So some people will say give benzos to this patient so they're cooperative. One of the problems you run into, especially with these rather large patients, Matt put the TFTB, too fat to breathe. When you give them a sedative, you'll find that their respiratory effort drops off pretty precipitously, even if it's something just as simple as two of Versed. So a lot of times with these patients, I'll forego the benzos and make sure that they can pre-oxygenate really well. I definitely would not give them fentanyl until they're pre-oxygenated. They went through a fiber optic intubation in this case study. As I said, I probably wouldn't do that, but if you're going to do that, things for you to think about: what you can do to topicalize the airway, lidocaine nebulizer, transtracheal block, popsicle stick with lidocaine jelly on it. You can use nasal airways soaked in lidocaine. A lot of different things that you can do to kind of prepare the airway. Generally, what I will do is a lidocaine nebulizer and then a transtracheal block. And the reason I do that is because if I have a failed airway and I wind up having to correct this patient, I've already identified and confirmed the landmarks. And I quite literally will take a surgical marker and draw a line on the cracked thyroid membrane so I know exactly where it is. From an anesthesia standpoint, induction with propofol is fine. There's not really any big hemodynamic issues you have to worry about. He's just big. Uh, kind of standard maintenance phase. Keep him relaxed, keep him comfortable. This is somebody you probably want to make sure is fully awake. But with that being said, you want to make sure they're comfortable when they wake up. And it can be really hard when you have somebody that's that big to keep them comfortable but have them breathe. Because if they're too sedated, they won't breathe real well. Some of these patients, I'll go ahead and just put nasal airways in before they wake up. So if they obstruct, I've kind of bypassed that tongue already. And that is kind of a nicer way for them to wake up than me trying to shove something in there. Other things for you to think about with this patient, they've got a history of asthma, so they're increased risk for bronchospasm. But just because you're hearing wheezing doesn't necessarily mean it's a bronchospasm. It just means there's some sort of restriction. So think about other things that could be causing that. It could be your tube is kinked off. Sometimes you'll have secretions in there. Sometimes the cuff will have migrated, so you'll actually have the cuff sitting right at the vocal cords as opposed to through them. And you may have some air leaking around there. You may have right mainstem to the patient, so look at your airway pressures. Especially in the setting of asthma or bronchospasm, you may see that it's difficult to tell whether you've right mainstem to the patient because they've already got elevated airway pressures. But that's definitely something for you to think about. One of the big things is just make sure the patient's adequately sedated before you start instrumenting their airway. Treatment for the bronchospasm there, good idea to go ahead and deepen your anesthesia. Sevoflurane is the preferred agent for patients with reactive airways. And especially as much as I like isoflurane, I would avoid it. And I would definitely avoid desflurane. You'll see when you get to clinicals that des tends to make everybody cough. So if you've got somebody that's already got a reactive airway, last thing you want to do is have them coughing. You can go ahead and nebulize the patient afterwards. Some places have inline nebulizers for their circuits. Some places you just kind of ghetto it with a handheld MDI and just spray it into the tube, which is less than desirable, but it actually works fairly well. Just an interesting side note there. If you have the option of giving somebody a nebulizer or an MDI, they work a little bit differently. What you'll see if you look down on kind of a smaller level, the MDI produces very fine microparticles that are actually going to go further into the airway as long as they take good inspiration. Sometimes you have to coach people through using their MDI because they don't do a very good job with it and it doesn't penetrate very far. The nebulizers actually have larger particles, so they don't penetrate quite as well as they should. But again, stand there and watch the patients as they're using this. If they just put the nebulizer in their mouth and just kind of breathe normally, you're not going to get great penetration. So start off with big, deep breaths. Make sure they're getting as far as they can into those terminal airways. All right, so let's talk a little bit about kind of what happened as far as the induction sequence here. If you do start off with kind of a traditional DL or glide scope and you have a failed airway, maybe you're having a hard time ventilating the patient, you don't have a fiber optic scope available, you can always try just mask ventilating the patient. The other thing you can think about is putting an LMA in. It may improve your ability to ventilate the patient. And then when you do have that fiber optic scope available, you can usually intubate through that. One thing for you to keep in mind is just the type of device that's available for your practice and move forward with that. Some of them you can intubate through, some you can. So if I was using it as a backup airway, I would try to always make sure I had one that I could pass a bougie, an endotracheal tube, or a fiber optic scope through. And that can kind of save you with this patient. The other thing to think about, if you didn't anticipate this was going to be a difficult airway, you may want to let the patient know post-procedure that there were some issues. We had a hard time putting your breathing tube in. That way, if they require any sort of surgical procedure in the future, they'll be aware of it. So that's just kind of a general overview of the case. One of the other suggestions from the program was you put an arterial line in this patient. I probably wouldn't, but the other thing is I deal with a lot of these kind of obese, borderline unhealthy patients. Something for you to think about in that setting is how is the patient going to be positioned? So if I were kind of back and forth about making sure I had adequate access or considering putting in an arterial line, and I had the arms available to me, and what I mean by that is that they're supine with their arms out to where I could put another IV in or I could put an arterial line in it during the procedure, I probably wouldn't. On the other hand, if it was somebody I was back and forth about and I thought I might need the arterial line, but they were going to tuck the arms, where they wrap sheets around them and put them right beside the body, I may consider going ahead and doing that. One thing you'll see is that you start having these thoughts, and you're never going to regret following these thoughts, but there's going to be a lot of times you'll be like, man, I thought about that and I should have done it, but I didn't. Over time, the number of those gets less and less because you've got kind of situational familiarity. So you know you should have done something, and the next time it pops up, you're like, yep, I'm just going to go ahead and do it so I don't get myself in a bad situation. So, what other questions do you guys have about the case study? So, Ray's question, and I understand disliking the scenarios. Unfortunately, computers only do what we tell them to do, so they take their programming and follow it to the T. Like I said, like the fiber optic intubation, I probably would not fiber optically intubate this patient, but that was the pathway they wanted you to follow. Um, so I can't do anything about the programming, but the big thing is I want you guys to start thinking about these different scenarios and putting thought into it. And I think that was definitely accomplished. Next, you could purposely give a beta blocker and it did not worsen the bronchospasm or make any appreciable difference. Um, you'll see that a lot of times beta blockers really don't make the big difference that we think it does. Most patients are on routine beta blockers and it doesn't affect things. But we know that from a chemical standpoint, it should. Next question, why do we have to overpressurize the SIVO to 3%? Wouldn't a lower percentage be sufficient? What you'll see if you have somebody that's having a laryngospasm, you're going to want to do exactly this. You're going to want to overpressurize them. And 3% might be low. You may be turning it all the way up to 8% to try and saturate those receptors so you're able to get the bronchodilation as quick as possible. Um, because it's very time dependent. So if you're kind of gently breaking the spasm, um, it's not going to work out real well for you. You want to do it as quickly as possible. So you're going to overpressurize that patient and get the SIVO in there quickly. One comment was it wouldn't let her pass until she did 5 of MAC. That is realistic. You're probably, like I said, going to turn that SIVO up to 5%, 8%, and go from there. You'll see when you start doing like your pediatric inductions that we commonly induce those kids with 8% SIVO. It seems like an awful lot, and until you really start doing it, it's kind of a strange concept, but it would actually work out. Carissa's comment, I couldn't understand why I couldn't break the spasm with propofol or sucks. So you have to remember that this patient's having a bronchospasm, not a laryngospasm. So laryngospasm should break with propofol or sucks. A bronchospasm may get a little bit better with propofol, but sucks really isn't going to affect anything at all because you've already got that tube through the trachea. It's not a laryngospasm. Uh, Armando found an article talking about 8% SIVO. Um, so, like I said, you may see that commonly used. Kate's comment, it also only wanted albuterol, but there were several other NEBs, MDIs you could have used. In practice, it's primarily going to be albuterol or a DO-NEB, depending on the patient. There is some other stuff that's used. One of the things that's on here is aminophylline, which doesn't get used very often, um, but it's definitely a possibility there. Apparently, the simulation just did not like Ray. He tried albuterol, atrovent, propofol, overpressurization, but he only passed with 3% SIVO and epi. So, um, I don't know. Like I said, computers are programmed to do what they're programmed to do. Um, Roberto's question was, oops, that was Nika's question. Sorry, it's scrolling faster than I can read. How can we tell the difference between a bronchospasm and a laryngospasm? So, first of all, think about when you encounter it. If you have an endotracheal tube in a patient, they can't have a laryngospasm because physiologically, what happens when you have a laryngospasm is those vocal cords are slamming shut. Usually, it's due to some sort of stimulation. Maybe you didn't suction the patient adequately, and they got some like secretions on their vocal cord.
Dr. Cornelius, you're muted.
Oh, thanks. I don't know how that happened. Somebody must have got tired of listening to me. Um, did you guys hear any of what I was talking about for bronchospasm and laryngospasm?
No.
Okay. What was the last thing you guys heard?
That you can't laryngospasm once you've intubated the patient.
Okay, cool. So if you've got somebody that's intubated, they've got that tube in there that's holding the cords open. Usually that laryngospasm is going to come from secretions or stimulation. Maybe like you went to intubate a light patient and you bumped the vocal cords with that endotracheal tube and the cord slammed shut. Um, so if you have a tube in there, they cannot laryngospasm. So the most common time you're going to see laryngospasm is going to be post-extubation at the end of the case. Maybe you didn't suction them adequately. Maybe they weren't quite awake enough to protect their airway. And usually, kind of the sequence is they'll cough, they'll sputter, and then you notice that they're not moving any air at all. Bronchospasm usually happens on the front end. So you've got a patient, you induce, you put your endotracheal tube in, and you notice that maybe you're getting a lot of high pressure. You're getting CO2, you're usually getting some sort of good return there, but you're not able to get adequate tidal volumes. Your airway pressures are really high. Sometimes you can hear it audibly before you even listen to their chest. Other times you're going to have to listen to their chest and realize that they're wheezing, or maybe you don't even hear wheezing because they're not moving enough air. So that's kind of your differential for bronchospasm. So the other thing is think about the patient. Bronchospasms tend to come from smokers and those with like reactive lung disease, so like asthma, emphysema, COPD, bronchitis, that sort of thing. You could also see bronchospasm as part of your symptoms from an allergic reaction. So it could be kind of hard to figure out exactly what's going on. And that's why we put epinephrine so high up, kind of the treatment algorithm for those patients. Because if it is an allergic reaction, it's going to present that way. You may have some other physical findings like a rash or something like that, but usually it's going to be increased airway pressure and that sort of thing. Roberto asked, would ketamine be a good option to relieve the bronchospasm? Ketamine would help. It's not going to be your initial treatment just by virtue of the fact that it takes a little bit longer to work. So initial treatment options, try and get albuterol in there because it's going directly to the lungs. You're trying to get your oversaturation of the volatile anesthetics because that's going to work directly on the lungs. And then you can start looking at IV stuff, more propofol. Ketamine is a great bronchodilator. If you have somebody that you're anticipating that they've got bronchial issues, that's definitely something I would consider incorporating into your anesthetic plan. But it wouldn't be your first choice. And the other part of that is usually it takes you a second because you don't have ketamine ready to go. Whereas albuterol is there, turning your gas up takes seconds. So those are kind of your more initial treatments. Jason said, after the bronchospasm, patient kept crashing because of increased intrathoracic pressure. Was that due to auto PEEP? Quite likely. So what will happen if you have somebody with bronchospasms, they're not able to move that air in and out of their lungs. So you may see, as kind of counterintuitive as it is, that these patients do a little bit better by reducing your airway pressure. In fact, sometimes you actually have to take the patient off the ventilator for a second and let them have a full exhalation because they will trap so much air in there. I had a patient 3 years ago for a hernia repair that had horrible undiagnosed pulmonary hypertension and COPD. And we found that he actually did much better by us taking him off the vent, letting him breathe spontaneously, than having him on the vent. We wound up canceling the case anyways, but he did substantially better when we reversed the muscle relaxant and let him breathe on his own as opposed to being on the ventilator there. I did not laryngospasm. Although, with that in mind, especially as we head into the winter and when you guys start getting into your peds, you'll see that like runny noses, coughs, those sort of things definitely predispose patients to laryngospasm and reactive airways. Ray's question, would you first assume right main stem with low tidal volumes and high pips? I certainly would, especially in a tube I just put in there. So if you think about your confirmation, so we watch the tube go into the trachea, we look over, we're checking our tidal volumes and our airway pressures, and then we're looking for those 3 end-tidal CO2 waveforms of equal height. So with that in mind, I know that the tube is in the trachea. The next thing you're going to do is start listening to your breath sounds. So like I tell you guys, go to that left axilla and listen there first. because the most common thing for it to happen, especially in pediatric patients, is that that tube's going to go a little bit too far and wind up in the right main stem. One thing you may try, depending on where your tube is, if you've got a slower like a tube that seems like it might have been in a little far, start pulling it back. You can always take your laryngoscope and take a peek. We don't do a whole lot of chest X-rays in the operating room, but if you're getting ready to do an orthopedic case and they may happen to already have the C-arm in there, you can consider just getting a chest X-ray real quick to look and see where your endotracheal tube is. Other things, you can try and palpate the cuff on the endotracheal tube. Usually it's going to sit right above the manubrium. So if you take one finger and stick it right there at the manubrium and push in on the trachea, and then take your other hand and squeeze the pilot cuff on the endotracheal tube, a lot of times you'll be able to feel it if it's in good position. That's not 100% accurate, but again, it's something you can consider. And then finally, you can always take a bronchoscope and run it down and see where your endotracheal tube sits and see where the carina is to make sure you're not right mainstem. One of the most common settings for that right mainstem intubation to happen is pediatric patients, because the physical distance is so small from being in good position to being right mainstem. A lot of times just movement of their head will be enough that next thing you know, the tube's right mainstemmed. And then, do we want a slow rate? It won't allow us to change the IE for the auto PEEP. A lot of times you're not going to have a slow rate. What you're going to have to do is think about the appropriate tidal volume for that patient and respiratory rate and kind of see where that gets you. So usually that's 6 to 8 mLs per kilo, rate of 10 to 12 to 14. See where you start off with that. If you notice that your airway pressures are extremely high, you may have to decrease that tidal volume and increase that respiratory rate. Again, you're trying to maintain that same minute ventilation, but you've got to compensate for it somehow. So drop your tidal volumes down, do the math. If I'm going to drop my tidal volumes down by 50 mLs per kilo, then I'm going to have to make up for it by adding X number of breaths per minute. Aaron's question, what do you usually do for airflow versus inhaled agent adjustments to 8%? Do you just increase your agent to 8% or do you change your flow rate at all? Now, anytime you're trying to make like a substantial change in your patient's condition, so say like this patient that's having a bronchospasm, if I turn that SIVO up to 8%, I'm also going to turn my flows up because I've got to get it in there quickly. If you're just trying to make gradual changes during the case, you see that your patient's heart rate or blood pressure is kind of trending upwards, so you turn on a little more gas. You probably don't need to increase your flows for that. But if you're trying to make a quick change, you're going to have to turn your flow rates up. Think about it like if you're giving a medication you want to get in your IV quickly. If you push a medication and you want it to get into circulation quickly, you're going to increase your flow rate and get it in there. Same thing with your bottle agent. If you're trying to get that 8% in there quickly, you want to make sure that the flow rate is there with it as well. Ray's question, is this a logical process for bronchospasm? Disconnect from the vent, manually bag, check the circuit, ensure not kinked or right main stemmed, adjust your head position, then suction, ensure adequate sedation, then albuterol. So it's kind of hard to have it in a step-by-step fashion. A lot of times what I will do, if I can look at the vent and see what my airway pressures are, I'm probably going to leave them on the vent. Even though our natural inclination is to want to squeeze that bag, most of these patients will actually doing better being manually ventilated. You'll see the patients with the auto PEEP are kind of the exception rather than the rule. So I would put that manually bagging a little bit further down the line. The exception to that is that if you need to be able to check your breath sounds, if you've still got them on the vent and you're doing 10 or 12 a minute, that means you've got to wait 5 or 6 seconds to be able to check breath sounds again. So for that standpoint, I may consider turning the vent off and squeezing the bag while I listen to their check. Next thing you want to do, you'll see it kind of referred to as the dope mnemonic. Kind of helps you troubleshoot your endotracheal tube in your ventilator. So displacement, make sure you still got CO2, check your breath sounds. Obstruction, take a look at the tube, make sure it's not kinked, make sure it's not main stemmed, make sure they're not biting on it, make sure you don't have secretions in it. Head position shouldn't really be a factor because your tube should be in good position, so moving the head shouldn't really affect things. Suctioning may be necessary. You'll learn by looking at your capnography waveforms. You can usually tell if you've got secretions in your endotracheal tube. Instead of having a nice crisp waveform, you'll kind of see some fluttering, or you may almost see it'll look like a line on the end of your ventilatory waveforms because it's just not either inspiring or expiring completely because of those secretions in there. If you suspect this is bronchospasm due to inadequate sedation, go ahead and turn up your volatile agent and start blasting them with that. And then try and get some albuterol or Atrovent or something like that in there if you can as quickly as possible. Like I said, I would probably try and keep them on the ventilator for that as much as I could. The other thing you have to think about from a workflow standpoint, it may just be you. So if you're standing there squeezing that bag, it's really hard for you to do 10 other things. So you may, after the initial period where you confirm the patient's wheezing, or maybe you already knew they were wheezing, I'm probably going to leave them on the ventilator so I have both hands free to do stuff. Because the other thing, you'll forget that you're supposed to be squeezing that bag while you're trying to troubleshoot things. And then, your patient who wasn't doing real well already is now desetting because you're not breathing for them. So what flow rate in that scenario is too excessive with our SIVO? Do we go for a flow rate of 5 or 10 liters per minute? No, I would definitely turn it up to like 6-10 liters per minute. Think about you're trying to get that agent in there as quickly as possible. The only thing that really changes is the burn rate of your SIVO. So if I have somebody at 1 liter versus 10 liters, you'll have a little bit of change as far as your airway pressures, but the big thing you're going to see is you're just going to run through your volatile agent faster than you would at a lower flow rate. Um, and she said she couldn't pass until she got to 10 liters per minute. So, any other questions about that? If not, we'll hop into the. Yeah, I would definitely, Ray, like I said, he asked about prophylactically administering albuterol. I would definitely do that. Like I said, I would give these patients albuterol and holding just based off their history. And then, if something bad happens, I would have it sitting there ready to go. And then on the back end of this case, before I started waking that patient up, I would consider giving them more albuterol because the problem you run into is coming out, especially with the risk of secretions. That's when you have to worry about them coughing, sputtering, and bronchospasm again. So I would definitely consider albuterol on the back end as well. The rest of the dope mnemonic Richard asked about. So displacement or obstruction of the tube, pneumothorax, which again could be indicated by airway pressure, and then equipment failure. So your ventilator could stop working. You could have some issues from that standpoint, but that's generally pretty clear when your ventilator stops working. And you can always consider taking them back to hand ventilating if possible, if you think your ventilator is the problem, or maybe even taking them off the ventilator entirely and putting them on an ambu bag. Is there a goal in tidal CO2 level? No, it's just patient dependent. There's not a magic number. Appropriate dose of propofol to break the bronchospasm. Again, it depends on the patient. If you think that they had this bronchospasm because they were not adequately anesthetized, you may consider starting off with like 20 or 50. The other thing that kind of comes into play is what did you have left over? So maybe you had 200 milligrams in that syringe and you induced the patient with 180. So I've got 20 sitting there that I can push quickly. I'll give that, and then I may consider getting more. Kristen asked about would you consider atropine for the secretions? You could, but a lot of times just because of concerns over heart rate, we'll use glycopyrrolate instead of atropine, especially like smokers, people that are already juicy anyways. I'll give them glycopyrrolate and holding ahead of time. And in fact, if I give large doses of ketamine, I'll consider doing that as well. One problem you may run into with some of these patients, if they've got thick secretions already, if you give them glycopyrrolate or some other anticholinergic that's going to dry stuff up, it's harder to get those secretions mobilized and suctioned out. So as gross as it is, I'll take like slimy secretions over real thick secretions any day. All right. So from there, we're going to move into talking about some obesity. And like I said, a lot of it tied into this case study. So even if you were frustrated with the case study, it was definitely helpful for you guys to do because it let you kind of start thinking about these things that you're going to experience in real life. So I'm going to try and share my screen. Keeps wanting me to update to some new version. Are you guys able to see that okay? It's just popping up some weird message and not wanting to do what I want it to do. Can you see it now, Kelsey? All right, let me try stop presenting and try doing that again.
We can see it, but you're muted again, Dr. Cornelius.
I think Teams hates me today. I'm not really sure what that's about, but that's okay. All right. So obesity is kind of considered a disease now. It's gone from a societal problem to a syndrome to an actual disease process. And over time, it's one of the biggest things that we're facing in healthcare. Nation or worldwide, there's about 1.6 billion people that are obese, and overweight, and about 400 million that are actually obese. Close to 40% of America is considered overweight or obese at this point. It's second only to smoking as far as the number of deaths we experience. And while the deaths don't necessarily come from obesity itself, it's all the associated disease processes. So diabetes, hypertension are two of the biggest ones that we see that kind of run hand in hand with obesity. Something else you see is, hang on one second, let me make sure it's still recording. Yeah. All right, cool. Is we're starting to learn more about the role of genetics in things. We're understanding that there's a lot of factors that go into stuff. So, we've always gone kind of the easy ones that, calories in have to be less than calories out to be able to maintain or lose weight. But we're figuring out that that may not matter so much. It could be what calories, when, and then again, the genetic makeup of things. Hormones play a huge role in it. So you guys will see, we laugh about people putting on weight when they get into residency. And part of it's probably tied into like stress eating, but the bigger part of it may be the stress, not so much the eating, because you stop sleeping, you eat bad, you have no sort of schedule. So you may see that that plays a large role in some of our patients as well. On the other end, you may see patients that are extremely malnourished because they have all sorts of weird things going on. Maybe they stay up all night doing Red Bulls and Monsters and playing Xbox, and they don't actually eat. Or maybe they get the munchies while they're playing Xbox. I don't know. The other thing you'll see is that there's some behavioral, cultural, and socioeconomic factors that are tied into obesity. If you go back and look historically, those that were obese were considered rich because they had the money to afford food. So kind of times have changed. So how do we determine obesity? We generally look at the BMI. The problem you run into with BMI is that it was developed by insurance companies and it doesn't account for a lot of factors. But with that being said, it's the most commonly used and readily accessible scaling out there. And it's pretty straightforward. You just take the patient's weight in kilograms and divide it by their height squared in meters. The problem you run into is it doesn't differentiate between being overweight and overfat. So if you think about somebody that's extremely muscular, most people that are really ripped will show up on a BMI chart as being obese or morbidly obese. Not every time, but you may also have people that are substantially muscular, but they also have a decent amount of fat that overlies that muscle. Like I said, we don't have another formula really to replace it, but there's some out there. Some places they look at waist circumference, some they look at waist to hip ratio, some place they look at waist to neck ratio, and then age also plays a role in it. We know as we start getting a little bit older that we develop more obese patients as well as kind of obese tissue. So there's two primary distributions of the fat. You have android patients, which is kind of truncal obesity. And it's important for us because these patients with the truncal obesity generally have an increased oxygen consumption and they also have an increased risk of cardiovascular disease. Then you have gynecoid obesity, which is more of like peripheral obesity. If you look at hips, butts, thighs, sometimes you'll see arms. Those patients are generally less metabolically active, so they have less cardiovascular activity. But you also see that those patients, even though they're obese, they don't have an increased risk of cardiovascular disease, which kind of throws us sometimes because we'll look at somebody's arms or legs and we're like, wow, those are huge, but they don't have any other disease processes. So continuing on down the cardiovascular pathway, what happens with cardiac patient or obese patients? You see that because of the increased tissue, they have an increased total blood volume. But most of that tissue or most of that blood volume is lost in the adipose tissue. So it's not necessarily a useful blood volume. But with that being said, if you have somebody that, say, has a traumatic injury or has surgery and they lose X amount of blood, they probably had more blood to lose. So their blood loss may not directly correlate with a decrease in their lab values because you're looking at something that's a straight number versus a percentage of their blood volume. Because of that increased circulating blood volume, you do generally see their cardiac output goes up. And as part of that, you'll also see that their left ventricles tend to become a little bit dilated, a little bit thicker, and they have an increased stroke volume because they've got to get that blood out through more tissue and further distances away. They also have an increased risk of cardiac dysrhythmias, primarily due to fatty infiltrates of the conduction system. They do have an increased risk of coronary artery disease, peripheral artery disease, and as I said before, a lot of times you'll see that they have kidney damage, that sort of thing, either due to systemic hypertension or those fatty infiltrates. When you look at an EKG, you may see that they've got low QRS voltage, purely due to the impedance of the tissue. If you think about it from an electrical standpoint, the monitoring electrodes are further from the source. So you've just got more resistance between the heart and where you're monitoring it. Because of the ventricular dilation, they commonly have LVH and a left axis deviation. From a hematologic standpoint, a lot of times you'll have a higher level of fibrinogen, factor 7, 8, and von Willebrand's factor. Tends to lead to hypercoagulability, which can be really problematic in these people, especially if you have somebody with peripheral obesity, because they may not have great perfusion anyways, and now you've got somebody that's got an increased risk of clotting. They may be sedentary on top of that, so they're kind of the perfect setup for DVTs and PEs, especially if they have like a big change. You have somebody that's bedridden and all of a sudden they start developing, for some reason they go on like a diet and exercise plan where they start working out more. Or you've got somebody that was bedridden and now they start moving around. You may see that they tend to shower peas at that point. They also have an increased risk of endothelial dysfunction due to the levels of circulating factor 8 and von Willebrand's. GI standpoint, the gastric volume and the acidity are increased. They also tend to have delayed gastric emptying just by virtue of being obese. But if you add in diabetes on top of that, or any of the other disease processes, as well as kind of what they're consuming, they tend to have a higher carbohydrate or a higher solid diet than a lot of healthier people. So you may see that their gastric emptying is even more impaired. So it's kind of the perfect setup for an aspiration pneumonia or an aspiration pneumonitis. Things we really keep in mind is kind of the cutoff point for that is somebody that aspirates more than 25 mLs of gastric contents with a pH less than 2.5. So it's pretty easy to have that low pH. It's the volume that tends to be a little bit harder to come by. And that takes us back to our pre-lecture discussion where we were talking about laryngospasm. So you may see that these patients start aspirating and they present with these coughing fits. And these coughing fits may really be that they're having like micro aspirations. They wake up at night coughing and sputtering because they're regurgitating whatever they had in there. So you see that happen, unfortunately, pretty common in those patients. They just don't really understand what's going on. And that's part of the reason when we start doing that preoperative assessment, we ask so much about regurg, gastric reflux, and that sort of thing. Other things to see in these patients, their hepatic function and drug metabolism may be altered. It's not uncommon to have patients with increased alcohol use that may also contribute to their hepatic function being decreased. And when you start looking at their intragastric pressures, the actual pressure inside the stomach, you'll see that it increases. And there's two other things that tend to go along with that. Because of overstress, you tend to see that the lower esophageal sphincter, that thing that keeps stuff in your stomach, relaxes a little bit easier because it's constantly under pressure. And the other thing you may see is that they actually develop a hiatal hernia over time, which may contribute to reflux, or again, may contribute to kind of that choking feeling. Or even though it seems kind of counterintuitive, they may have difficulty getting all their food to pass. So they may tell you that they eat and they kind of start choking, and that may make you think that maybe there's some sort of hernia that's going on there that you don't know about. From a renal standpoint, they generally have increased renal blood flow, increased renal tubular reabsorption. Unfortunately, that tends to impair the natriuresis, and it does activate the renin-angiotensin system. So we can see that it tends to have associated hypertension for those patients if they're not getting it for other reasons as well. From an endocrine standpoint, you tend to see an increased level of SNS activity. So they're primarily, if they haven't already developed it for another reason, they start to have insulin resistance. Their glucose metabolism isn't quite as good as it used to be. You tend to see an increased pressor activity of norepinephrine and angiotensin 2. So again, think about somebody that wasn't perfusing real well, had increased hypercoagulability, and that pressor activity may lead to vasoconstriction that again leads to those blood clots. They tend to retain sodium either by virtue of a poor diet or what's going on physiologically. And it's not terribly out of sorts for them to develop resistance to thyroid hormone. So about 25% of these patients will actually have hypothyroidism. With that being said, you may see that when they go on Synthroid that they're able to lose all that weight. The other extreme is you may see sometimes people are diagnosed as being hyperthyroid because they have a substantial weight loss. So if you have somebody that is obese, one of the common workups for these patients is going to be to check their T3, T4 levels. Diseases that are commonly associated with obesity, we usually think of diabetes. Primarily, it's going to be type 2. Type 1 diabetics are generally not obese. A matter of fact, they're usually underweight, but there are exceptions. And you'll see, especially if you have somebody that's diagnosed with adult onset type 1 diabetes, that they may go through violent changes in their weight. They may be obese, and then without even trying, they lose large amounts of weight. A lot of times they come in for kind of cancer workup at that point, and good news for them, it's not cancer. Bad news for them, there's type 1 diabetics. Other things you'll see just due to body habitus, obstructive sleep apnea. Again, one of the big questions we ask during our preoperative evaluations. Go back to those snoring questions, ask the relatives. It's not out of sorts for them to be on CPAP or BiPAP at night. A lot of times they'll have asthma or other pulmonary diseases. It may be exercise induced or just restrictive due to their body habitus. You'll see sometimes these people are smokers. They may have COPD as a result of their smoking, or have smoked in the past, which is, of course, great for their cardiovascular system as well. So it goes hand in hand with that they tend to be hypertensive, either because they have to have higher pressures to reach that distal tissue, or because they've got atherosclerotic diseases, they've got plaques everywhere, they've got occlusions. It's kind of a vicious cycle. You see a lot of these things kind of tie into other things. They do also have an increased risk of some cancers and some, because of that, we're starting to figure out that there may be an increased dietary role of what's leading to some of these cancers, especially like GI cancers. So we'll see how that plays out. That's kind of a new area we're looking at, is really the role of diet in cancer. And then finally, just because of physical strain, they tend to have osteoarthritis. So we see a lot of these patients that will come in for joint replacements. And as part of that, the surgeons usually require them to get their weight down to a certain point, because they don't want to do a replacement on somebody and then have them, fail because they didn't maintain their weight loss. So a couple years ago, we started putting together something that was kind of pre-diabetes, and we called it metabolic syndrome. And it's a cluster of a whole bunch of different abnormalities people see. Usually we require at least 3 of these for a diagnosis of metabolic syndrome, but abdominal obesity, decreased levels of HDL, elevated triglycerides, elevated insulin, glucose intolerance, hypertension, some sort of prothrombotic or pro-inflammatory state. Usually that's going to come from your coag evaluation. So when you start seeing these things, and the big ones we tend to see are cholesterol abnormalities, obesity, and hypertension. And then you start seeing the A1C creep up. And then after that, we go back and look at like the pro-inflammatory and pro-thrombotic states. Start thinking this is somebody with the possibility of developing metabolic syndromes. Other things you'll see, look at patients with elevated waist circumference, not necessarily BMI. We know that it increases in risk with age. Men are more predisposed to it than women are. And we tend to see this increasingly in minorities, Hispanics, South Asians, African Americans. But now I think we've kind of gotten to the point where it's widespread, although we do tend to see more of it, as I said, in minorities. Part of that may be due to altered socioeconomic factors, and part of it may be genetics. We know that, especially in African Americans, there's a strong genetic predisposition towards some of these syndromes. Other thing you may see that causes it, long-term corticosteroid uses. So if you see somebody that's been on steroids for a long period of time, they come in, they've gained weight, they don't sleep, they've got that paper-thin skin. So, we always attribute this to diet, but there may be other factors involved. Like I said, it could be genetics, it could be medications. A lot of the psychological or psychiatric medications will affect it as well, either because of the underlying medication or the underlying disease process or the medication itself. So antidepressants, antipsychotics, and then finally protease inhibitors also tend to cause metabolic syndrome. So why do we worry about it? What we see with those patients with metabolic syndrome is they've got an increased risk of cardiovascular disease. A lot of times their insulin and glucose resistance turns into type 2 diabetes. They also have an increased risk of polycystic ovarian syndrome. They may develop NASH or non-alcoholic fatty liver disease, and they don't respond to things appropriately. So you'll see that their responses to infection or some sort of other event are just altered. So the good news is that about 98% of these patients will have their metabolic syndrome resolved through bariatric surgery or reaching their weight loss goal. As we're seeing more and more patients get bariatric surgery, they're having better outcomes and living longer. The other thing, and I don't think we really have enough research on it yet, is a lot of the diabetic medications are being used as weight loss medications now. Like I think one of them's Mounjaro and some other stuff. I'm not sure if those will play out long term, but they do seem to help patients get to their goal of reducing their weight at least. So talking a little bit about obstructive sleep apnea and hypoapnea syndrome. Obstructive sleep apnea means that for some reason they've completely stopped breathing. As I said, it's usually due to that obstruction. It usually lasts 10 seconds or more, and it usually happens at least 5 times or more for each hour of sleep. So if you think about it, that's like a minute an hour that they're not breathing. It's kind of awkward. And the other part of it is that you generally will have a decrease in their SpO2 during that time period by at least 4%. The other thing you'll see is hypoapnea. They don't actually stop breathing, but they do decrease their airflow by at least 50%. Same kind of basic criteria. It lasts about 10 seconds or more, but it happens more frequently, usually 10 to 15 times or more per hour of sleep. And again, you see a decreased SpO2 at that same time period. So how do we evaluate that? We'll have the patients come in for a sleep study, which is also known as polysomnography. And they're going to look at the number of events that happen per hour divided by the total sleep time. So low end, 5 to 15 events per hour, high end, 30 events per hour. So can you imagine somebody having 30 events an hour where they stop breathing for 10 seconds? It's kind of crazy. You can imagine how that would not be restful, and the immune response to it would be pretty severe. So how do we treat that? Initial treatment is targeted at the source. So is this due to an obesity problem? If so, we generally try and work towards weight loss. The other thing is we try to support the respiratory system. So we'll usually try CPAP or BiPAP. You'll see that as a result of it, they tend to have an increased risk of either systemic or pulmonary hypertension, left ventricular hypertrophy, cardiac dysrhythmias, and cognitive impairment. So if you're not sleeping, it does tend to affect you. We've all had that one day where we didn't sleep real well and we were a little rough the next day. But imagine if every night you were having these periods of hypoxia and waking yourself up or waking others up. You can see how over time that would definitely wear you down. All right, so the next thing after that is obesity hypoventilation syndrome, also known as Pickwickian syndrome, or you may, as Matt so eloquently referred to it, as too fat to breathe. So Pickwickian syndrome results from long-term obstructive sleep apnea, and you generally see this in about 5 to 10% of the morbidly obese. And what happens now? They're actually having kind of severe cardiovascular side effects from it, and it's usually a two-part process of pulmonary hypertension that leads to cor pulmonale after that. Diagnosis: BMI greater than 30. My experiences has generally been greater than 50. 30 is just the number they use as a cutoff. And these people are wide awake, but they breathe so poorly that they start to become hypercapnic. So if you can imagine, you bring this person back to the operating room to induce anesthesia, and you put them on there and their CO2 is already 50 or 60. They can't lay flat. This may be one of those patients you have to induce sitting up. So when you start having people that are elevated CO2 levels, if they're not smokers, think that there might be something else going on there, especially if they do have this pretty significant obesity. So from a medical standpoint, how do we treat this? Primary treatment is phentermine, and basically it works by decreasing your appetite. The FDA only approved it for 3 months, but as we see a lot of times with treatment of bariatric patients, people kind of do their own thing. You see kind of shady clinics where they're passing out medications without really evaluating people. You come in and pay your $25 per shot, and they'll give you whatever. So you may see that used for longer periods of time. One of the issues we run into is a lot of times patients that are on phentermine will not respond appropriately to treatments for hypotension. So if you have somebody that's on it, you probably want to make sure they stop it for 10 to 14 days pre-procedure. And what you'll see in those patients is tachycardia, hypertension. They may develop palpitations or flushing. And it's pretty easy for them to become dependent on it, either by virtue of they're happy with the results, or you almost get a little high out of it. There were some medications, well, I call them medications, over-the-counter stuff, 15, 20 years ago that contained ephedrine. I don't know if you guys have been around long enough for that, but it was real popular in the gym. And they started taking the ephedrine out of it because young people were having cardiovascular effects. And then they started trying other things. Ma Wong was one of them, and they're always looking for like the quick fix for some of the stuff, and it just doesn't really exist the way that we'd like it to. And you guys may have had some personal experience with some of that stuff. You may have to have some of it right now. I don't know. Other things you'll see, orlistat, which blocks the absorption of dietary fat. These patients will have liquidy, oily stools. Fecal urgency is probably an understatement. You'll see that not only do they have the need to go, but a lot of times they quite literally can't get to the bathroom before they do, because of the large amount of oil in it and it primarily being liquid. If they use it for long periods of time, they may start to have some hematologic effects. One of the big ones is vitamin K deficiency. So you may see that their PT is prolonged. And then you may see all sorts of other stuff that's over the counter. You may have some of the pancreatic lipase inhibitors like caffeine and green tea. You may, like I said, see some of the appetite suppressors, ginseng, ephedra, sunflower oil. You may see a lot of these used in conjunction. A lot of times you'll have an appetite suppressor with an energy stimulant. And then you may see some of the other stuff that helps with lipid metabolism, fish oils, soybeans, and then some of the teas again. So how do we evaluate the patients here? There's a lot of things that come into play, but usually we're going to focus on those disease processes. So you'll see a lot of patients that come into you and they're healthy by virtue of the fact that they don't have any diagnoses. So they walk in looking like a train wreck, can't breathe, can't talk. Their blood pressure's through the ceiling, but they're healthy because they haven't gone to the doctor. So when these people come in, you really have to start looking at all the factors that come into play and figure out if this is truly a case that needs to be done now, or is this somebody that needs to be evaluated better. Big things to look for are evidence of hypertension, diabetes, CHF, and then the hypoventilation syndrome. So you'll see that if you have somebody that's got a CPAP greater than 10, they're probably going to be difficult to ventilate. And the reason they're difficult to ventilate is because they have so much redundant tissue there. If they're requiring that much CPAP to keep their airways open, you'll find that they're very hard to ventilate. So a lot of times we try and get those patients intubated quicker so we don't have to worry about ventilating them for as long, or consider an awake intubation on somebody. Other things, look back at their surgical history. If you've got somebody that's had some sort of bariatric procedure, look at their current weight versus their past weight. If they had 50 years of obesity and then they had a procedure done, there was still a lot of damage done to that body in that time period. So they may have some underlying cardiovascular diseases. With that said, you'll see a lot of times patients that have had these bariatric procedures, when they have them done, they are able to come off a lot of their medications. Their body almost resets itself. So it may be a kind of a nice thing, but it's definitely something you want to keep in mind. Other thing for you to think about, the ease or the difficulty of intubations. Just because people are large doesn't mean they're fat on the inside. You may see that there's just lots of redundant tissue on the outside and they're very easy intubations. But it's a lot easier to have somebody prepared for things to be difficult and not need it than to figure out the hard way that you've got a difficult intubation you took pretty casually. IV access can be extremely tedious in these patients. The use of ultrasound has really helped out, but you've got to make sure you've got long catheters. A lot of the kind of standard veins we go to, hands and anacupitals, may be difficult to get to. One of the nice ones is if you look for things that have applied pressure like watches or bracelets, you may be able to actually find veins underneath those just because they've been compressed for long periods of time. You may see these patients need to go to the ICU post-operatively for cases that you wouldn't normally send somebody to that doesn't have all these coexisting diseases. And with that in mind, you may have to look at your hospital's facilities. A lot of the smaller critical access hospitals or even surgery centers have BMI cutoffs because they don't have the capability to manage these patients post-procedure. So you've got to always pay kind of a close attention to what the surgeons are trying to slide by you. We keep pushing the limits of what we're doing in critical access hospitals and surgery centers, but it's not always appropriate. And sometimes the bad outcome for a patient is what changes things. Other things for you to consider, we usually try to continue all their home meds. There are some exceptions. You may stop their antihypertensives, especially ACE inhibitors. And you've got to pay attention to what's going on with their diabetic regimen. So long-term insulins and long-term oral hypoglycemics can be problematic, especially if you're going to make a patient NPO. On the other hand, you try and maintain kind of hemostasis there. So if you're sending their blood sugar really high because they're not getting medication, it can be problematic. So it comes into play not only evaluating where their blood sugar stands, but how you fit them into the schedule. Maybe it's better for them to be able to get up and have breakfast and have their case done later in the day. Or make sure their case actually happens when it's supposed to. Most of these patients get standard antibiotics, DVT prophylaxis, and aspiration prophylaxis. It may be increasingly important for these patients just because of their higher risk of thrombotic events and aspiration. We're going to talk just a little bit about kind of airway physiology and capacities and volumes and stuff. This is more just a review. I'm sure Dr. Schmidt went over this in great detail. But the big things for you to think about is you tend to have a decrease in vital capacity, a decrease in inspiratory capacity, a decrease in expiratory reserve volume, as well as a decrease in FRC. So pretty much everything decreases in these patients. They tend to have poor compliance, and you'll see that their closing capacity is close to or within tidal breathing, especially if they're laying flat. So that's part of the reason it's so much easier for these patients to breathe when they're sitting up or when they're standing up. And you may see that when you start doing your preoperative evaluation, if you talk to them, they haven't been able to sleep in their bed for years because they can't breathe that way. So they sleep sitting up in a chair. And when you think about your induction on this patient, same thing. You may have to induce them with them upright because they start to have trouble breathing when they lay flat. They become panicky. And usually they're right. They tend to desaturate pretty quickly. So especially when you're starting off, these are those patients that pre-oxygenation and good pre-oxygenation are really your friend. Just throwing the mask on there for a minute or two may not be adequate. You may need 5 or 6 minutes of good observed tidal volume to get them adequately denitrogenated so they don't desaturate on you quickly. And just a quick review of the volumes if you need a reference point for it. So we're going to talk a little bit more about closing capacity. And closing capacity is really just the volume in the lungs when the bronchioles collapse. It's usually less than the FRC because your alveoli remain open during inspiration and expiration. But what you see in patients with bad lungs is that it collapses at a higher volume. So they're not able to completely exhale. So you almost have that auto PEEP scenario we were talking about before. So they're retaining higher volumes in those alveoli. As a result of that, they tend to have hypoxemia because of the VQ mismatch. Think about them not being able to get bad air out and good air in. And then the other thing you see is they have increased atelectasis. So they may be at higher risk for pneumonia on top of all their other issues. So when we get to the operating room, things to think about. You've got to alter some stuff. Positioning is a big one, especially as it ties into airway management. But we're going to talk a little bit about positioning on the bed itself. Obese patients are at increased risk for pressure injuries, and it can be problematic for us for sure. Airway management can be difficult in these patients, so we're going to talk about some alternative strategies for that. Monitoring may be different. Sometimes these patients, because of their coexisting diseases, we consider using monitors that we may not normally use. Your anesthetic technique may be altered just because you don't want to put this patient to sleep. Pain control can be difficult because in these patients, if they're already hypoventilating, medications that cause respiratory depression can be problematic. And then finally, fluid management can be difficult. If they're already edematous, the last thing you want to do is make that worse. So there's different issues that we run into with all the positions. So there's not a perfect one for any of these patients. Things you have to worry about if you've got somebody supine, ventilatory impairment. We just talked about how their closing capacity is affected. You may see that their girth compresses their IVC as well as their aorta. And sometimes just because of the sheer weight laying on the patient, you may see that they've got an increased risk of rhabdomyolysis on their gluteal or posterior muscles. You can see this on other muscles too, just depending on how long they're in position. And in these patients that are already kind of unhealthy, it's pretty easy for them to quickly get into renal failure. With prone patients, you may see that because of the way the beds are designed, that they may have excess pressure placed by the cushioning pads. And I've got some pictures we're going to look at here in just a second. And on those pressure areas, you may see that you have skin breakdown, some tissue necrosis, and that can lead to infections. Patients turn lateral. Again, you may see that the dependent hip has excess pressure, and as a result of that, you get ulcers. You may get tissue necrosis there. You may see that it's impossible to or unnecessary to place axillary rolls. It's kind of funny, but kind of not. You'll struggle to lift up this really big person to put this axillary roll in there, and then it's just absorbed. You can't tell that you put the axillary roll there at all. So sometimes it's not really necessary to have it there. We tend to favor lateral decubitus over prone for positioning. So think about patients, a lot of times they'll come in with like gluteal injuries or maybe for hemorrhoids. It may be easier to put these patients in a lateral position than truly turning them prone, especially from a ventilatory standpoint. With lithotomy, you may see that regular stirrups are not adequate to support the weight. And because of that, you may have equipment failure. And then the other thing you might see is that because of the actual tissue compression, these patients can develop compartment syndrome pretty quickly. And if you think about longer surgical cases, you have increased risk with that as well. So this is just an example of lateral positioning. You can see that the axillary roll is up there, and it's really just kind of been absorbed by the patient. If that towel wasn't sticking out there, you wouldn't know it was there at all. Their girth tends to shift around, so you may find that the operating room table is not adequate for the patient. They do make extenders that are pretty beneficial, but you may have problems with extenders because the surgeon's not able to get into the patient. And you'll see some sketchy stuff happen. From a legal standpoint, I would discourage you from improvising on these patients, but I've seen 2 OR tables pushed together. I've seen patients have surgery on the floor because they were too big to go on a table. And it's very fine line because the patient needs the procedure, but you're shifting the risk from the patient not taking care of themselves to us for doing something that's probably not real acceptable. So you'll see a lot of times this happens. Other things for you to think about these patients, especially if they're turned lateral, kind of the joint between the arm board and the bed itself, making sure that that's lined up well because it could be problematic for you. So here we have somebody that's in a supine position, but they're also kind of in a lateral position. And as you look there, one, it's just a hot mess, but you can imagine how difficult it is to ventilate that patient and then all the areas you have to worry about here for pressure. You look at those stirrups for lithotomy, pressure on the calves. You've got somebody we're using Coban to hold on the operating room table. If she starts to fall, the Coban's not going to hold her. It may make us feel a little bit better about what's going on, but it's not going to work. So this is one of those cases where I'm talking about from a legal standpoint, you don't have a leg to stand on if this patient were to fall. So this is a patient that's turned prone, and you see very easily there what I'm talking about. Those are the positioners, and they may not fit the patient very well. So you'll see that they've had to pad the rails on the Jackson frame because the patient's girth is actually hanging down into the frame area. So imagine the tissue ischemia that they're going to experience along that. They wake up from surgery and they've got some abdominal numbness because some strange nerve was compressed while they were there. These can be a mess. The other thing you'll see is it happens, not a lot, but if it happens, it's primarily going to be in this patient population, that you will turn them prone and you just can't adequately ventilate them. Either they've got bad lung disease or there's just something else going on. And when you turn them prone, the airway pressures get so high, you can't keep them in this position. So sometimes you're able to flip them back supine, maximize them, and get them turned again. Other times you just have to stop and see what else you can do. Take them back, see if they can lose weight, see if from a cardiovascular or pulmonary standpoint you can do something to improve them. But these can be really challenging cases. Here's another one. This patient's in a little bit of like a jackknife position. It's kind of hard to tell based off the body habitus. But imagine trying to position this patient where you've got them up so their girth is off their chest. Because if they're laying right on that chest, you have a hard time getting chest extrusion. So that can be problematic as well. At least we're using actual straps to hold this patient on the table. But what are we using down there at the feet? We've rolled a table over there to put his legs on. Again, somebody bumps that table out of the way or they get a pressure injury there. Not a good setup. And then if you look down there at the base of the table, almost all the operating room tables we now use, you can shift the surface. So you may be able to center it over the pedestal or the base, or you may be able to slide it one way or the other. You've got to be extremely cautious because the weight capacities change when you shift that base around. So if I've got somebody, if they're centered up over top of the pedestal, it'll take 500 pounds. If I move them to this extreme position, that pedestal is not going to support it, and they're at high risk for that table tipping over. And again, they're going to go back and say, this was the weight capacity. You rolled a table over here to put the patient's legs on. You're probably going to lose out on that one. Any questions on like the positioning side of that? All right, just looking back through that. So what do we do in these situations? If it's elective stuff and you don't have the adequate equipment for it, you need to stop. Richard's saying if it's life-saving, you got to do it. You can have them sign whatever, but it's going to be essentially a consent under duress because you have this patient that needed to have the surgery or they were going to die, and you said, well, you have to sign this piece of paper or I won't do the surgery. That would never hold up in court because they were only concerned about living. You were concerned about your liability. A court would never support you there. So the biggest thing is to think about these cases before they come. Know which operating room tables will hold which patients and go with that. And make sure you have the right equipment. Don't be trying to put tables together and roll beds in and all sorts of stuff. Have designated obese tables that have adequate frames and recognize if you're starting to get into an uncomfortable or inappropriate position. All right, so moving on to airway stuff. As I said, this is kind of the second thing we worry about. They may not be fat on the inside, but they also could be. So you may see that you've got increased adipose tissue deposited into the uvula. the tonsils, tonsillar pillows, the tongue, the epiglottic folds, and the lateral pharyngeal walls. So everything on the inside might be fat, just like everything on the outside. In fact, one of the things you'll see done for these patients is they'll go through and do a uvuloparingeoplasty, where they reduce the size of the uvula, and that helps out with the snoring. Not real common, but you may see that happen. It's a little bit more common in patients that are not obese, but do have edema or swollen uvulas. The other thing you see is that it changes the oropharynx into more of an ellipse. So it's not that nice round shape anymore. It suddenly kind of stretches out. And you generally see an inverse ratio between the degree of obesity and the pharyngeal area. So it makes sense as the degree of obesity goes up, the pharyngeal area gets smaller. So other things for you to think about, BMI is not necessarily an independent predictor. Look at other things. So you may see that even though they're obese, they've got a great mouth opening, or they may not. They have a very small mouth opening. So the more of these you kind of see start adding up, start thinking this may be a pretty difficult intubation that you're looking at. If you've got somebody with large or protuberant teeth, think about like that kind of buck teeth or beaver teeth, that can be problematic for you. If their neck doesn't move very much, again, it can be difficult. And then finally, micro or retrognathia, if they've got that recessed jaw, again, it's a poor, or it's a good indicator that they're going to be a poor intubation success rate. So the ramp position, and there's a couple different examples here, but basically what you want to do is line up the external auditory meatus or the ear with the sternum. So you've got a couple different axes you're going to line up here, and I'll show you that picture in a second. But if you look at the pictures over there on the left side, you know, this is a lot of the facilities I've worked at. We don't have like nice pillows. Some places you go and they've got like little inflatable things, or like this is the intubating pillow. Most of my past has been done with sheets, blankets. We didn't even have real pillows. But you can see how much better her positioning is in the lower picture than the top picture. The other thing you'll see is when you get them in this better position, they breathe better. So instead of in this low position, where really her chest is going to be up on her chin, it's not going to be where it is in that picture. It's hard for them to breathe. On the right side there, you've got an intubating pillow. The other thing for you to think about, a lot of times you can just sit the head of the bed up for these patients and they'll do okay as well. So this is just kind of helping you get a visualization as you start lining up the different axes. So you've got the three axes there, the oral axis, the pharyngeal axis, and laryngeal axis. So as you elevate the head, you also want to remember that you want to tilt the head back a little bit. And you may need to elevate the shoulders as well as the head. It may not just be the head itself, especially as the body habitus goes up. You might kind of start moving your ramp further and further down the patient. So this was a kind of cool study they did. They had simulated endotracheal intubation and looked at the angle of the bed and the height of it on patients. And what they found was the patients did really well as they were ramped up. And they also found out that if they were able to pre-oxygenate them, they did a little bit better. I know this is shocking, but there's always people out there that are like pointing out the obvious through research studies. This study here looked at desaturation time. And what they found was patients with a normal BMI would desaturate to 90% over 6 minutes after being adequately pre-oxygenated. Morbidly obese patients would drop in about 3. And I think both of those are probably overestimated. I think in reality, you're probably looking at about 2 or 3 minutes till normal people start to desaturate. Morbidly obese, you're probably looking at 30 seconds to a minute. So what can we do to help these patients out? One of the big things is recruitment. So if you can, maybe we're doing like a lower extremity orthopedic procedure, keep them in a head up position during the surgery. If not, is they're like putting dressings on or you start getting ready to wake the patient up, go ahead and sit them up. Allow them to get that chest expansion. If it's a procedure where they have to stay supine, perhaps you can put them in a reverse Trendelenburg position. Again, allow those lungs to expand and displace their abdominal girth off of their diaphragm. Other things for you to think about, CPAP during pre-oxygenation, close that APL a little bit so they're getting a little bit of airway pressure in there. And then towards the back end of the case, again, make sure you're getting some recruitment maneuvers in there, whether you're doing some stretch breaths, some variable tidal volume breaths, any of those sorts of things. And even though it seems very counterintuitive, these patients actually do better getting on the ventilator quicker. We think we have great hands and we can ventilate patients effectively by hand, but the ventilator is far better off for them. So a little bit about anesthesia techniques. Um, so we start looking at a lot of factors here, and things you have to think about as far as aspiration. Obesity is not necessarily the only factor, but it definitely increases the risk of gastric volume and pH. Um, you may also see this in other patients, but obese patients are the big ones we worry about. And then as we start adding on factors, they're diabetic, they're obese, for some reason they've got another impaired gastric emptying, we start adding on more treatments for these patients. So if you've got somebody that's already a little bit increased risk, consider doing like a histamine receptor agonist, a PPI. Finally, a lot of these patients we're going to go ahead and do as an RSI just to get that airway secure quickly. And then finally, you may consider moving on to just doing an awake fiber optic intubation on these patients. Other things for you to think about, if you have anybody that you're concerned about not being able to ventilate or aspirating, I would probably consider moving quickly to an RSI. With COVID, we kind of did away with the test ventilation on these patients and started applying muscle relaxant quickly. And we found out that we had less desaturation and our concerns over difficulty securing an airway were kind of alleviated. So regional anesthesia, as far as a technique in obese patients, is definitely safe. But it can also be challenging. One of the populations we commonly see that have kind of a temporary obesity or OB patients. And you may have OB patients that are large, or it may just be by virtue of their pregnancy. The nice thing about regional stuff, you can generally avoid the airway. A lot of times we avoid the cardiovascular depression. As part of the medications we give, we don't have the high risk of PONV. And they usually get better post-op pain control from a regional technique versus a IV or opioid-based technique. The downside, these cases are technically difficult. You may need longer needles. You may have to use different ultrasound probes. You may have to transition to one of the convex probes as opposed to kind of the linear probe. You may see that these patients require smaller doses in their epidural because their epidural space is actually smaller due to the tissue compression. The other thing, by virtue of the technical difficulty, there's a higher rate of block failure. Anatomy that looks crystal clear may not be what you think it is. I had a patient a couple weeks ago that I was doing a femoral block on, and it turned out that he had a superficial femoral artery that was huge. And I hadn't looked down far enough to figure out that that was his superficial femoral artery, not his femoral artery. When he had difficulty with the block and I went back and looked again, I actually scanned all the way up almost to his abdomen and figured out where I really needed to be. You'll also figure out, especially with like blind techniques like epidurals, that there's a high risk of failure for these patients. Landmarks are very difficult to identify. And then the other thing you'll see is that a lot of times, especially with neuroaxial stuff, you have a higher rate of hypotension due to the abdominal compression of the IVC and the aorta. Other things that come into mind, we're kind of lazy sometimes, and we may not use the appropriate size blood pressure cuff. So what you'll see is that sometimes we put a cuff on that's too small, and it gives us a falsely elevated high blood pressure. The cuffs are actually marked for the circumference that's appropriate for them. But you'll see a lot of times that, we have a cuff that's supposed to go on somebody's upper arm, and it doesn't fit, so then we put it on their forearm. Again, it alters your measurement of the patient. The other thing you'll see is that sometimes because of the physical shape of their upper arm, blood pressure cuffs may not fit on there. So one thing I would encourage you to do if you're using different locations for blood pressure cuffs is maintain consistency throughout. So if you're going to put a cuff on a forearm or a calf, do it ahead of time. Get a baseline pressure there before you go to sleep. Because you'll get it in pre-op one place, then you move it someplace else, then you move it someplace else. And it's really hard to establish consistency that way. The other thing you'll see is that a lot of times we have to do additional monitors for these patients. So if you've got somebody with bad pulmonary hypertension, you may consider putting in a PA catheter or a TEE to monitor them. You may see that because of their obesity, you have a hard time getting IV access. So the ultrasound's been kind of a game changer, but we still see a lot of times in these patients, we have to put in central lines because we can't get adequate peripheral access. You may see, because of their increased risk of DVT and PE, because of their hypercoagulability, they may get IVC filters placed a little bit faster, especially if they're going to be in hospital or bedridden for a while. Because of the hard time getting non-invasive blood pressures, we tend to put arterial lines in these patients a little bit more. The nice thing is, usually if we have that arterial line in there, we can keep a better eye on our labs, including our ventilatory status. From a medication standpoint for drugs and dosing, there's not really like a particularly great anesthetic plan for any of these patients. There's kind of drawbacks to all of them, and we're going to talk about some of the big ones. For opioids, propofol, and benzos, a lot of times you'll see an exaggerated response. So these patients may become apneic quicker. They may be more sedate even from lower doses. As part of that, we tend to use short-acting stuff. So remifentanil, dexmedetomidine, ketamine. Some of those are kind of nice because they go away quickly. When you start thinking about longer-term stuff like morphine or hydromorphone, they stick around for a long time. And it's really hard to find a balance for these patients between making them pain-free or sedated and then having them breathe adequately, especially at the back end of the case. Almost all these medications are going to decrease the muscle tone in the pharynx. And as part of that, they also decrease your risk of airway patency. So one of the big concerns for these patients is on the back end, make sure that they're awake and able to protect their airway. We don't do deep extubations on obese patients because of the high risk of failure. Another thing you'll see as far as the volatile agents go is that they tend to diminish the response to CO2. So if you have somebody that's getting a large amount of isoflurane, you may see that it takes quite a while and their CO2 has to go up higher before they want to breathe. And then finally, just kind of a note on nitrous, and people go back and forth on this, but a lot of times, especially towards the back end of the case, we won't use nitrous on these patients because they do have an increased oxygen demand. So if you've used nitrous, you want to make sure that you've turned it off and that you've really washed it out with a large amount of oxygen, especially towards the back end of the case. So dosing guidelines, and we could go back and forth on these, but they're primarily based on the lipid solubility of the drug. So usually off of ideal body weight, we'll base our sedatives, propofol, our muscle relaxants, and remifentanil. On the other hand, for total body weight, a lot of times we'll look at midazolam, Sux, Nimbex, fentanyl, and sufentanil. One thing I will usually do for these patients is figure out which is less. Usually it's going to be their ideal body weight, and use that as a jumping off point. And I can always give more. It's kind of hard to take it away. From a volatile standpoint, desflurane is probably favored, but desflurane is expensive because of the increased risk of respiratory complications like the bronchospasm patient. Des is probably not good for this folks. And then the other thing is we're starting to learn that there may be some environmental consequences to the use of des. So there's not a good answer. The other thing is really going to depend on where you go. Some places use des for everything. Some places don't have a des vaporizer anywhere. You can get by with any of the volatile agents. It just takes a little bit of learning on your part. Other things for you to keep in mind, and we kind of talked about this earlier, make sure for your operating room table that they're weight appropriate. You're using actual safety straps. One of the things that you may not have seen before is called a bean bag. It's kind of like a vacuum mattress, and we'll help use those to stabilize patients that don't really fit the bed. So if you've got somebody you're turning them lateral, you may take a bean bag and wrap them around them to kind of help stabilize them on the bed. One thing you want to be really cautious with on those patients is what's between the bean bag and the patient. Sometimes we'll put sheets in there, and the sheet will get like bunched up underneath of them. And then you finished up the case and they've had like breakdown in this line where the sheet set. So pay attention to that. There are some like sheets out there that are designed to be used with bean bags, but it's definitely like a high risk thing when you start turning these large patients. The other part of that is because of their larger surface area, they can be very hard to manage from a thermal standpoint. So I usually try to pre-warm these patients and then keep them as warm as possible throughout. Because they take a long time to warm up just because of their sheer body mass. Other things for you to think about, like I said, people do some sketchy stuff. You'll see like extra arm boards put on there, Mayo stands, tape comes into play a lot of times, or Coban. Whatever's being done, keep the patient's best interest in mind. You may see that you have to put expanders on the bed. There's not a perfect answer for a lot of this. Like we were talking about, if the case needs to get done, it probably needs to get done. But try and have the best equipment possible for these patients. From a fluid standpoint, you'll generally see that these patients require a little bit more fluid than usual to make sure you're preventing acute tubular necrosis. And a lot of times they don't respond appropriately or demonstrate their response appropriately to volume. So some of the monitors, especially the non-invasive ones, may not give you an accurate measurement of their volume status. All right, so we got through the case. Now we're on the back end. As I said, with these patients, you want to make sure that you're getting them in a better pulmonary position. So sit them up, put them in reverse Trendelenburg. I'll usually go ahead and move them over to their stretcher to sit them up because I can raise the head of the bed up there a little bit better. The downside is you may figure out that you need a stool. And whatever you're doing, keep in mind that you want to be able to reintubate the patient if need be. Just because of their poor cardiovascular and pulmonary status, they have a higher rate of reintubation. So make sure you're ready for that. Other things for you to think about, make sure that you've fully reversed their neuromuscular blockade. Sagamedex is indicated for all of these patients, and you'll see even in facilities that kind of control who you can give Sagamedex to, that obese patients are usually like number 1 or number 2 on the list. Now, what they call obese may vary. Sometimes it's a BMI greater than 30, sometimes it's 40, sometimes it's 50. But I would certainly consider it for those patients. On the back end, when you start letting these patients emerge, we have this habit to kick them over to breathe spontaneously. And one of the problems is you go through this transition period. You've had them on the ventilator with great tidal volumes, and then you turn the ventilator off, and their tidal volumes drop off. As soon as that happens, you kind of lose all the recruitment you've accomplished. So you may consider leaving them on pressure support a little bit longer as they're emerging. Afterwards and into the recovery room, if you have CPAP available, for perfectly fine to use theirs. If not, talk to respiratory before you roll back to make sure that they're going to be able to meet you in recovery with CPAP or BiPAP. Post-operative pain standpoint, consider opioid sparing or non-opioid medications, especially for patients that are high risk for respiratory depression. And then finally, consider when and where cases are done. If you've got somebody that's challenging, don't do that case at the end of the day when you've got less help available. Same thing, we try not to do these cases in surgery centers. You know, if this is somebody that's going to GI for something, you may want to consider moving the case to the main operating room. Just think about, logistically, the what ifs. The last thing you want is this 500-pound patient in a broom closet having a GI scope done when something bad happens. They're probably a little bit better off going to the main operating room. So that's what I've got. What questions do you guys have? All right, so Haley's question, once intubated, do you return them to supine or whatever position the surgeon wants, or do some people requiring ramping throughout to reduce the airway pressures? And she kind of got her answer. So what you'll see happen really depends on the facility. Like if this is somebody that you've had to ramp up for intubation, and maybe they're having abdominal surgery done, they're probably not going to be able to do it with them sitting up like that. So you may have to sit the patient up and pull all that stuff back out from underneath of him. Some of the newer positioning devices are inflatable, so you can just deflate it. I've seen them, haven't had the opportunity to really work with them, but a lot of times you'll have to take that stuff out. And that's part of the reason on the back end, I move the patient over to the stretcher before taking the tube out so I can get them back over there and sit them up. Yes, Kristen, I've done cases on the floor. I've done cases in the dirt. I've done all sorts of stuff. I've seen OR tables strapped together. I've seen cases done on like the bariatric beds because that was the only thing the patient would fit on. I did not do any cases at LSU on the floor. Yes, there are some people that are too big for body bags and all sorts of stuff happens. Sometimes they try to put body bags together. Sometimes they wrap them in sheets. So, as far as the improvising goes, it should make you nervous. When you start doing things that are outside the standard, you should be concerned about it. But sometimes it's the best outcome for the patient. But always kind of stop and think, is there something I could do to make this better before we go back? Whether it's giving that patient an albuterol treatment or saying, hey, we probably need to wait a week or two until your pneumonia is resolved, or any of these sorts of things. So think about that basic stuff. If it's an urgent case, it's an urgent case. It's going to have to get done. All right. What other questions do you guys have?